So we're going to talk today, like Dr. Person said, we're getting more and more involved in the care of colorectal cancer patients. And why we're becoming more and more involved is there's been a little bit of a shift in how we work this up. And the lungs are colorectal cancer's number 2 most frequent metastatic target, secondary to the liver, which I think probably been discussed in other lectures, and that 10 to 15% of all colorectal cancer patients at some point develop a pulmonary met if they metastasize. And 32% of patients who have stage 4 cancer end up having lung involvement. And so the question then becomes, with all of these metastatic lesions, how do we get tissue and how do we get it safely? And so we're going to talk about that a little bit. So timing matters. We want to try and, these patients are they had their colonoscopy, they've had their diagnosis, they get the CAT scan, PET scan. Now we found the thing in the lung or the liver, and now this time is starting to drag, right? So, you got that colonoscopy, we waited for pathology. Well, now we waited 2 more weeks for the PET scan, and now we find a thing in the lung, and now we need to get that biopsy too. And so that's another week to get the bronchoscopy or IR biopsy, another 3 or 4 days to get the biopsy from that resulted back. And so time is just really dragging on. So, oh my gosh, how much longer is this going to take? And so when you get these biopsies, tissue is the issue, to quote some more punny sayings, is, and so we need to make sure that not only are we getting tissue in a timely fashion, but that it's helpful. You don't want to go in, you've waited all this time, you finally get that procedure, and then you shoot a blank. There's nothing there. So it's really important. So historically, I'm sure everyone's familiar with interventional radiology. Historically, interventional radiology was the way to go. You found a thing in the lung, that lung tissue until you get the thing. It's a great tool. Probably 95% sensitivity specificity with that biopsy, which means most of the time, if it's cancer, you got it, and if it's not cancer, it's not cancer. But that comes with a historic national complication rate of about 20 to 30% pneumothorax, or collapsing of that lung, which is not nothing, especially in the patient who's been smoking their whole life, and you pulled the cigarette out of their mouth on their way into the biopsy. So it's a little bit of a thing. These can be big time fatal, can be a fatal complication. And historically, it's been their only way to do it, though. Bronchoscopy, probably like 10 years ago, our biopsy yield was probably like 30%. Anything that was maybe 2 centimeters in peripheral. And these procedures took hours because you would go in there and then you just fish. I always tell people the lungs are like an upside down tree. We're driving from the inside of that tree. Everyone's got a trunk. Everyone's got the same 2 or 3 first branches. And after that, complete crapshoot. No one knows. You have no idea. Everybody's branches are different. You're just driving around like without Google Map, just looking for something. Which never happens to me when I'm driving. I always know exactly where I'm going. Ask my wife. So what we've gotten into the last 2021 till present is we've gotten into navigational bronchoscopy. We're the first center in the region to get this. And it's changed our practice rate. We have about 4% risk of pneumothorax since 2021. Actually, it's closer to 3%. And our overall diagnostic yield is about 90%. So we can get the same tissue safer, as quickly, with lower risk, and get more tissue frequently. So, and this doesn't come with just like a couple tools. Like, it's not just the robot like this, in which I'll show you some cases here in a little bit. But most of this comes from the multitude of things that have been added since that navigational bronchoscopy. So first off, we started with our robot, which is a really cool camera, basically, that we input your CAT scan. It creates a 3D roadmap for us. So literally we have like a Google map, and I'll show you an example of this, where we drive in and it says, go left, go right, go up, go down, go this way, go that way, until today you're there. Not 100% perfect. So for that reason, we about a year and some change ago, we got our own cone beam CT scanner in the room, so that once we get out there, we can do a CT scan and make sure that we're in the right spot. Very similar to what IR is doing. IR is doing the exact same thing during their cases. We can do the same thing. We have ultrasound device that's new. We have cytotechnologists who are in the room with us for every case. And then we've recently got a really amazing tool that I'm going to show you guys in a little bit called Van Gogh dynamic cell imaging microscopy, which is, it really has been a really interesting and exciting tool for us. So what it has meant for us is we can about 100% of the time get to the lesion. Our diagnostic yield, though, is about 90%. It allows us to do a lot of other types of biopsies. So we do biopsies where we'll throw a needle, kind of like IR does, but then we've also got ability to take bites of it and get huge chunks of tissue. And then recently what we've started doing is we've got what's called cryobiopsy. So we send this ultra thin catheter out, and then it just does a 360-degree circumferential freezing of that area of the lung, and then we just pop it out. And so it sounds a little barbaric, and it kind of is, you know. I mean, it's a little interesting to just pull out a chunk. I mean, it's a chunk, but even with that, our pneumothorax risk is very, very low. And these patients are all sedated; they have no idea, so it's totally fine. So here's kind of some of the tools that we have. Here's this pincher biopsy that we have. Here's a brush, really rudimentary. It's literally a pipe cleaner. This is our cryo device. And then this is what the other thing that we can do during our cases. A lot of these people will have synchronous mediastinal or hilar lymphadenopathy, or lymph nodes in the chest that are swollen or involved. So during that same case, not only do we look for that lesion, we'll look at the lymph nodes in the chest and biopsy those same time. Patients who, I mean, it happens where we'll get a referral for colorectal cancer. We think it's a metastatic disease, and then we go out to biopsy it, and lo and behold, that smoker who's been smoking for 40 years, who now has colon cancer, also has an asynchronous primary of a lung cancer. And that's why we biopsy, because then that changes our treatment pathway completely. Now it's not metastatic colorectal cancer. You've got stage 1 colon cancer, and you have a stage 1 lung cancer, which changes everything, rather than just assuming. And we can stage that cancer for the lung same time. So when we come out of our case, we can tell the patient, you know, stage 1 lung cancer, or we've got N1, N2 lymph nodes involved, to upstage and change his treatment. So this is a real case that I'm going to show you that we just recently did. So this is a lady who came to see me, and she had been working up for breast cancer, and the doctor got a CAT scan, and then we have this thing right here. So you can see it's like anterior to the mediastinum. It's super high. It's abutting the aorta. Something that for IR, you know, normally they would have to come. I don't know if my mouse works better, but they're going to come down like this. It's a lot of tissue for IR to go through, and historically, and then you've got that needle pointing like as a right into the aorta. So it can be a little hairy. They want to get that biopsy, but they don't want to get too deep and do a blood gas. You know, so they want to try and just get a certain range in there. So what we can do, and hopefully this will work. So kind of standing in the way. So this is a video that I took of real time of how this works. And so this is real life. This is computer generated Google map. And then this is then the other pictures, fluoro. And then up here on the top is kind of a representation of where I am when I want to look at where I am in the airway. And so I'll just move through this a little bit. But when we start driving, you can see that we can actually just, got to get moving. I was putzing around there for a little bit. So you can see now on this picture here in live view, it matches up pretty closely to that simulated version. And so we're just literally like driving along, making sure the whole way that those airways match up, because it's not perfect. It's still a computer, and it's still like you've got a moving person. And so we can actually just we plot our course around this, make sure our airways and the pictures are lining up. And you can see that in this case in particular, now this is perfect, right? That's why I'm showing this one. But in this case, we were able to go from start to stop in 2 minutes out to that spot, or just 2 minutes and some change. And I get out here and I fiddle fart around a little bit just to make sure that I'm completely in the right spot. But then what happens is we start sending out some other tools. And so once I've parked that device, this is actually a radial ultrasound. And radial ultrasound is just a 360-degree ultrasound. So here's the picture. Isn't that funny compared to the CT scan? That's why I have it here. Like it's so disproportionate. Like when you're looking at that, because you're just looking at an AP view of the chest, that's actually pointing basically towards me, you know, and when you look at this, it's like, well, that's not even close. You're not in the right spot at all. But what we find is that we stick the radial ultrasound out there, and this is some shadow happening. But because that's behind the airway wall, we can't even see it with the radial ultrasound. So then what we'll do is we'll take a fine needle, really tiny needle, and we just throw it through the airway wall. And I think, and this is, so then we're getting, because I'm nervous, we're doing a CAT scan here. So this is generating a 3-dimensional model. That's why it's spinning here, and you can see a little bit better. And then it reconstitutes that picture for me on my little console here. And that console then will re-update where that lesion is relative to where I am. Because as soon as you start the case, to remember when you get a CAT scan, if you've ever had a CAT scan of the chest, you go in the tube and they say, take a deep breath and hold it. And you hold it. And then, you get the scan. In this case, we intubate the patient. As soon as you're intubated, we start getting what's called atelectasis, and the lungs start doing this. And they're breathing. And so when I'm in there doing biopsies, we've got a patient who's breathing, their lungs are doing this, we're getting atelectasis. And so we have to account for all of that. And so here, pause, it would create it, but you can see right here, that's my catheter tip, and we've targeted it, and we're dead center or right up against that lesion. So that's when I'll start throwing the needle out and say, okay, I know I'm right knocking on it. And so we're gonna try and get some tissue. And so what happens, if I can move this along, we start throwing some needle biopsies. It takes a little bit of time to get the biopsies going. And I'm going to show you what happens to our radial ultrasound probe. Doing a lot of things here that I'm not going to bore you with here, but I want to show you if we can. Here we go. Should have timed where these all were. Maybe we won't get to see that. In the interest of time, we may move this along. So now we got, there we go. So now, it doesn't broadcast very well up here actually, but if you could see it on this computer screen right here, you can see that this mass lesion, we're right dead center in the middle of it. And so now we'll just start taking multiple biopsies out of that thing. And so we're at 12 minutes now, where we've done navigation, we've done CAT scan, we've done needles, and now we're throwing tissue into cup. So not very long. Here's just an example of why this cross-sectional imaging is so helpful. So this is a CT scan, and for all the world on X-ray, remember I was showing you how different it looked just from the X-ray view, which is what we historically had until a year ago. So this is not me. I didn't do this because I never would do this. But so you can see right here, this is the needle right here coming out of the sheath, and it's going right into the airway wall of the pleura. But if I have a picture also of the X-ray, but if you're looking at it on fluoro, it looks like you're dead center in the middle of the lesion and you're biopsying it. So it's really shifted how we practice. So, you'd have been biopsy, just jabbing this thing into the chest wall, and you'd have gotten a pleural biopsy. And instead, you get this scan, you see that, and you're like, ooh, pull back, and then reproximate. So we get the biopsies, great. We want to make sure that what we got is good. We don't have pathology in the room. We have cytotechnologists. So the pathologists in the room are the pathologists are the docs. The cytotechs are just technicians. So they can't tell us, you have cancer, you don't. You have a granuloma, you don't. They can say you've got a thing. We think you have something, which is fine usually, because we know what our pretest risk is when we're going in. But when we're talking about, well, I can't live with just, I have a thing, I want to know. Frozen takes about 20 minutes based on where we do our cases. So we don't do those very often because we're just sitting there twiddling our thumbs while the patient's under general anesthesia. So what we got recently is this thing called Van Gogh, which is a dynamic cell imaging microscope. And it is some crazy, we're not going to talk about poop here, I guess. But what we do is, it is basically a PET scan in live time. So we take the tissue that we biopsy, we throw it in this microscope, and what it looks for is metabolic activity. So it's basically doing the same thing as a PET scan, except we can throw it in the microscope and we get an answer in about a minute and a half whether we're in the right spot. Has crazy good correlation with final read by pathologists and is more sensitive than cytotechnologists. So it's been a really amazing tool. And so here, so you can see, are some examples. So this here, these blue cells, behind me, this is actually from a lymph node biopsy that I did on a different case for a different lady who had a lung mass, or not a lung mass. She just had big lymph nodes and she had breast cancer. And this is, that's actually breast cancer that's lighting up that blue color. Colors look different in the lymph nodes. That's breast cancer in a lung lymph node. This here, if you can see like this yellow slide, you know, this stuff here, this is all metabolically active tumor cells. This is a metastat. This is a primary lung cancer in the lung. And so when we're in the case, I know we've got it. And what's coming down from this, which is very exciting for our oncology partners, is that they're working on an AI algorithm supposed to be out in June, where I'll be able to put this slide in that system and it's going to tell me whether I have appropriate sample size for NGS, which is next generation sequencing. So you're going to leave, so there won't be the opportunity to like go get the biopsy and then the oncologist say, yeah, you know, you didn't quite get enough. We need to send it off for the super special testing, but we don't have it. We'll be able to leave the case knowing not only did I get it, I have enough. And this is a really cool one because not all things are bad. This is actually a big ball of histoplasma in the lung, which is a fungus. And these are all cases that I just did recently. But this is histo. So it's been a really amazing tool and it's correlated so far for us like 90-some%. And we can actually cut down through these slides. So like if we don't see it on the first pass, we'll go down 3 or 4 more passes through. It like cuts through almost like a real life pathologist, and then we don't lose the sample at all. So used to be you send this off to the cytotech, we put it on a slide, and then the slide is dead. Like whatever's on that slide, nothing more can be done with it. We just take this, we wash it off into our cytocup, and we can still use it. So not only do I know I have it, the pathologist is going to look at the same thing. And we can tell them, hey, that they just tell me they don't see it. We can say, well, actually, we had to cut down like 400 or 500 microns to see it. And we can tell them maybe you need to go back down and cut through it a little farther, and they do, and then they find it. So it's been unbelievable. So this is the robot. That's what it actually looks like. It's not really a robot. It's just a fancy camera. But our sensitivity and diagnostic yield matched these most recent studies of about 90 to 92% of finding the disease. And this is like, when people say, well, can you get that? And the answer is yes. I mean, this is a case that I did about a month ago. This is a 4-millimeter nodule on the pleura. I was feeling like a cowboy, so we did it. But this is all emphysema right here, that kind of like lace net disaster that's right here. All emphysema. This catheter is on CAT scan of me. This is the tool right there coming out of the channel, and that's the thing that we biopsied. That was squamous cell cancer. And because the risk is so much lower, like if you see all this emphysema, like that was a guaranteed pneumothorax 5 years ago, or even now. I mean, if you took this to IR now, this person's in the hospital with a chest tube for 2 weeks, probably. So all of this comes with a little bit of a price. This is a picture of what's happened to our bronch suite. When I started doing the bronchs in like 2019, when I came here, we had this way too big of a bronch suite, huge room, nothing in it. Now you can see it's kind of like I affectionately call it a clown car, because we've added all these things. And so I like to show this slide for people who want to give me money to buy new things. But so this is what the room looks like set up in real time. Here's our CAT scan machine rotating. Got the poor anesthesiologist trapped back there in the back. And then all of our other tools. And then in addition to this, there's typically 6 people in the room with us during these cases, plus whoever wants to come observe and someone wants to come learn. So it's an endeavor. And so normally I stand right behind there, right in front of the anesthesiologist. I don't do any bowel preps before these cases because I'm standing right in front of the anesthesiologist, and they would hate their lives. I'm sitting down right there. So basically, I'm running maybe a little over. So basically what we've done is kind of just grown and grown and grown our capabilities. Our volumes have grown by 30 to 40% year over year since 2021. We're replicating this actively in other towns, in Fremont right now. So we're trying to expand our footprint. We're trying to not necessarily, and IR is fine with this. Like they don't have, like there's no consternation. In fact, they're starting to review the cases and say, hey, maybe you need to send this for bronch, because not everyone knows that we can do this. It's like a primary care doctor gets a nodule and they'll say, well, let's send you to IR and get the biopsy. IR says, whoa, pause. This is something that we could send a net to bronchoscopy. It's a safer tool, and we can still get the same stuff. So we're trying to just cut down the number of steps patients have to go through, which we're able to do really efficiently now. Faster, safer. We've got more smart technology for us. And then this allows us to go back to the colorectal surgeons and the oncologists and say, we got it. Or thank God it's histo. It's not a thing, you know, and we feel really good about that. And I knew when I left the room, patients love that because they can say, man, I feel pretty good, 90% confident that this is not cancer when I walk out. And that's worth a lot. Now, I always caveat, like, I'm not a pathologist, we have to wait, but letting them know, or even at the time, like, you know, this really does look not good, because they leave the room and they want to know, and I don't ever know. So I just got this, and Kim was so nice to plug this in for me. But because this is like, do you guys like the Olympics? I fucking love the Olympics. And so they're always talking about, oh, he stomped that. This is my stomp, right? So this is my stomp. This is metastatic colorectal cancer in a lung biopsy that I just sent her. And that's what all these like yellow cells are in here, is all metastatic colorectal cancer. And this is kind of the simulated H&E. So we have the cytotech. They can look at this too. They don't have to do any of the staining, the dipping. There's no time. It's like bang, right here. And it took about 2 minutes. It's crazy. Can't be possible. I got lots of cool shit. I don't have, but I wouldn't be anything without the people that are actually backing the whole thing. So this is the bronch techs who are in the room with me. That doesn't include all the nurses. This is all the background staff who are trying to like make sure that I have the patient on the right day. These are who are coordinating everything. It's really crazy.
Today I'm going to talk about systemic therapy options in metastatic colorectal cancer, and we'll go through the past, the present, and the future. So I'd like to start off by some key statistics regarding metastatic colorectal cancer, some clinical pieces of data that I like to obtain before formulating a treatment plan. Then we'll go through the foundations of first-line chemotherapy options, 6 decades of trial in under 6 minutes. Followed by targeted therapies, VEGF-directed, EGFR-directed, MSI-high-directed, and BRAF-directed. And then lastly, I'll go over 2 of the latest updates that were presented in January ASCO GI 2026 in the metastatic space. So according to SARE data 2025, colorectal cancer cases in both men and women were about 154,000. It is the third most common cancer in both men and women, third most common cause of cancer-related deaths in men, and 4th in women. The 5-year relative survival is about 65%. We are seeing an increased incidence in the young adult population. So right now, about 20% of colon cancer cases are detected in patients under the age of 55. That number doubled since 2019, which then lowered our screening age for colonoscopy to 45. And there are talks of possibly lowering this down to even 40. Several factors are felt to be contributing to this increased incidence, mainly environmental factors, low fiber, high fat diets, genetics, as well as certain GI conditions. 23% of patients actually present with metastatic colorectal cancer, and the 5-year survival is very different than what we saw earlier. So it's very low, it's about 16%. So there are so many pieces of clinical data, and it's just like so many options, as you can see on NCCN. There's like a ton of options, and so these are the pieces of clinical data that I like to obtain before I tailor the therapy, and it's based according to the individual patient needs. So the first thing to take into consideration is patient characteristics. So although age is listed as the first data point there, it's not what I primarily use. First, I usually take into consideration comorbidities as well as performance status. And then I look at age as well, and whether they've received any prior treatments. Then we look at tumor characteristics. mainly the tumor burden. Are these patients presenting with oligometastatic disease, meaning just like liver or lung, or are they widely metastatic? And are they resectable? And this is where, our surgical colleagues, as well as radiation oncology, we have to have a multidisciplinary approach to these patients. And then we look at the tumor location. Left-sided tumors are treated very differently from right-sided tumors. Then we look at molecular characteristics. Are these patients RAS mutated, BRAF mutated? What is their MSI high status? And are they HER2 amplified? And then, of course, patient preference. At the end of the day, this is stage 4, and most patients will not have a curative option. So we do have to prioritize the quality of life and take into consideration the toxicity profile of the medications that we are using. All right, so I've got 6 minutes to go through 6 decades. Okay, so in the 1950s, we had 5-FU, and that is all we had until the 1990s. As compared to best supportive care, 5-FU was pretty much equal to best supportive care. Patients lived about 6 months after their diagnosis. We then had the combination era where irinotecan was added to bolus 5-FU plus leucovorin, and that showed an overall survival benefit of about 4 months. So we're making some progress here. We then found out that, then added oxaliplatin to the 5-FU regimen, compared that to the bolus regimen with irinotecan. That again showed an overall survival benefit. And there were 2 things that we realized from this trial. One was that the bolus regimen had more side effects than the infusional regimen, and that it was also, also showed an overall survival benefit as well. We then compared 2 regimens, FOLFIRI versus FOLFOX, and does it matter which one we start first? Both regimens were found to be efficacious, and it was pretty equivalent, and the sequence does not matter. What matters is the side effect profile. So oxaliplatin tends to have more neuropathy and neutropenia, so just higher infection risk, whereas irinotecan has more alopecia and diarrhea. And the way I remember this is I run to the can, irinotecan. Then we looked at capecitabine. So capecitabine has been shown to be, capecitabine in a combination, Capox, has been shown to be equivalent to FOLFOX or FOLFIRI, again with a different set of side effects. So hand-foot syndrome is very common in patients that are on capecitabine. We do not use Capox with irinotecan just because of overlapping toxicities. And then in 2006, we had 2, trials, Optimox-1 and Cairo trial. And this looked at whether we could use a stop-and-go approach, because oxaliplatin has cumulative toxicity, the neuropathy being one of the most limiting factors on, to be able to continue the drug. So this trial looked at continuous doses of FOLFOX versus dropping the oxaliplatin after 6 cycles, continuing with maintenance 5-FU, and then reintroducing the oxaliplatin at progression. And though there wasn't much difference in the overall survival, the patients that used the stop-and-go approach did have a better quality of life and less side effects. And of course, this is a stage 4 setting, so quality of life is something that we really need to consider. Then we came to the targeted therapy eras. So our first targeted therapy against VEGF was bevacizumab. So bevacizumab in combination with the bolus irinotecan and 5-FU did show an overall survival benefit of 4 months. And this was the first trial that showed, such big survival benefit in the metastatic setting. We then compared bevacizumab with either FOLFOX or Capox. Didn't really show an astounding overall survival benefit, but where the benefit was seen was in the progression-free survival. So it kind of led us to believe that the benefit of bevacizumab is not really in the upfront setting, but more in the maintenance setting. It's still an option to add in the upfront setting, but the most of the benefit is seen in the maintenance setting. And then we looked at bevacizumab plus FOLFOXIRI. I know there's a lot of letters here, but FOLFOXIRI is essentially a triplet regimen. You're essentially using all your key players up front, your 5-FU, oxaliplatin, and irinotecan. And that showed a pretty good overall survival of 31 months versus 26. However, this regimen is very toxic. It's difficult to treat, difficult to tolerate, sorry. And you're essentially, you're using everything you have up front, which then, what are you going to use after this? So we really reserve this for young patients, fit patients, and those that have very aggressive tumor biology. Then we came into our anti-EGFR drugs, cetuximab and panitumumab, which also showed an overall survival benefit of about 3 to 4 months. And this was looked at in the Crystal Fire and the Paradigm study. However, there were a couple of things that we found out from these studies, that the benefit was not seen in all patients. It was limited to those patients that had left-sided tumors, as well as those patients that were not RAS mutated, or we say RAS wild. It also, let us know that just doing basic RAS testing was not enough. So when you do just basic RAS testing, it only looks at RAS mutations in exon 2, whereas the extended RAS testing looks at RAS mutations in exon 2, 3, 4 in both KRAS and NRAS. And in doing that, we're actually able to identify 11% of patients which actually would not have benefited from the anti-EGFR therapies. And now we come to biomarker-directed therapies, and that's from the 2020 to our present day. So therapies that are directed against MSI-high tumors. So the first trial that came out was the KEYNOTE-177 that looked at pembrolizumab versus chemotherapy with bevacizumab plus minus cetuximab. That showed a really good overall survival of about 77 months versus about 37 months. However, 29% of these patients did end up developing progressive disease. We then had the study Checkmate, which looked at 2 immunotherapy agents, ipilimumab and nivolumab. And I know we're not supposed to compare these two drugs because there are no trials that compare them head to head. But just by looking at the data, so Ipi and Nivo had a 2-year progression-free survival of about 72% versus 48% in the pembro-only trial. Overall response rate of 71 versus 45, and 10% of patients in the Checkmate trial went on to develop progressive disease versus 29. So again, not supposed to compare the two, but dual immune checkpoint inhibitors, they are superior in their efficacy, but they also have more side effects. The other thing is that in the Keynote trial with pembrolizumab, the benefit was not seen in RAS mutated patients, whereas in the Ipi-Nivo, benefit was seen despite their RAS status. So mutational analysis matters, and sidedness also matters. So right-sided colorectal cancers, they are just more aggressive and have an overall worse prognosis as compared to left. So the right-sided, they tend to be more sessile, serrated, of mucinous histology. They're flat, so sometimes they can be more difficult to visualize. They are larger, they present in more advanced stages, and they are poorly differentiated. And these are the tumors that harbor the BRAF mutation and the RAS mutations. They tend to have more MSI-high disease, and they don't have benefit from anti-EGFR therapies. The left-sided are usually villous, and they have the typical adenocarcinoid histology. They're polypoid. They tend to be HER2 amplified, and these are the ones that do benefit from the anti-EGFR therapies like cetuximab and panitumumab, provided that they are RAS wild and don't have any RAS mutations. So I just wanted to go over the slide as to why these patients don't benefit from anti-EGFR therapy. So cetuximab and panitumumab, what it does is it, so you have your EGFR, and these drugs will block the EGFR pathway, which is upstream, whereas your RAS pathway is downstream. So in those patients that are RAS mutated, that pathway is still intact. So just blocking the upstream pathway, it has no effect on the downstream pathway and what's going on, below that EGFR mutation. So the tumors will continue to grow. You'll continue to see oncogenesis, angiogenesis, because there are other pathways that remain intact. So in summary, for first-line systemic therapy options, 5-FU and oxaliplatin or irinotecan or capecitabine, that is our backbone. FOLFOX versus FOLFIRI or CAPOX, sequence does not matter. Both are efficacious. In the United States, we tend to use more FOLFOX over FOLFIRI, or we start off with FOLFOX as opposed to FOLFIRI. The stop-and-go approach is validated, less side effects, better quality of life, and still very efficacious. Bevacizumab is an option in the frontline setting, but the benefit is more in the maintenance setting. FOLFOXIRI, very toxic regimen, but it is reserved for young, fit patients with more aggressive tumors. Sidedness matters. Right side, no benefit of EGFR inhibition. Extended RAS testing is necessary because the EGFR inhibitors will not work if they are RAS mutated. And the extended testing does pick up an additional 11% of patients that we would have not picked up from just initial RAS testing. And then MSI high tumors. Pembrolizumab is approved. However, dual checkpoint inhibition does provide better response, but again, with more side effects. So then I want to kind of move on to second-line therapies. And I've started this slide because I'm going to come back to these drugs towards the end of my presentation. So BRAF mutation, it occurs in exon 15. The only actionable BRAF mutation is V600E, and it's present in about 4 to 7% of patients. This mutation is associated with poor survival, and they also present with atypical patterns of metastases. So the BRAF inhibitors, encorafenib, was looked at this trial called Beacon trial. So in this trial, patients had already progressed on 1 to 2 prior lines of therapy. So there were 3 arms to this trial. So you had your triplet regimen, encorafenib, binimetinib, which is a MEK inhibitor, and cetuximab. So you might be wondering, well, why are we also adding EGFR inhibition in this BRAF mutation if the BRAF is downstream? So what happens is when you inhibit BRAF, it then releases a negative feedback mechanism. So then it restores the EGFR signaling. So that pathway then becomes reactivated. So you have to block them at both levels, EGFR as well as BRAF. So the triplet regimen was looked and compared to the doublet regimen, just encorafenib and cetuximab, and the control was cetuximab with irinotecan or FOLFIRI. Both the triplet and the doublet regimen did show an overall survival benefit of between 8 to 9 months versus 6 months in the chemotherapy alone regimen. And then there was a 40% reduction in risk of death. The doublet regimen, less drugs, better side effect than the other regimens. Then we have our anti-HER2 directed therapies, again approved in second line and beyond. Unlike the anti-HER2 response or the agents that we saw in breast cancer, they're not as effective in metastatic colorectal space. So HER2 amplification is seen in about 4% of colorectal cancers. The drug that you decide on using, it really depends on the RAS status as well as the IHC stain. So the first approved drugs in this space was tucatinib and trastuzumab. We then had the antibody drug conjugate trastuzumab deruxtecan, which is approved for patients that have HER2 amplification of IH3 3+ or 2+ with FISH amplification. And this drug was actually shown to have benefit even in the RAS mutated patients. And then we have the dual HER2 blocking agents, trastuzumab and pertuzumab. And then lastly, we have some, we don't see a whole lot of these cases. We have our KRAS G12C, which is the only actionable mutation in the RAS family, and NTRK fusions. So adagrasib is what we use to target KRAS G12C. And then we have larotrectinib, entrectinib, and repotrectinib for NTRK fusions, but these are very rare. Third line and beyond, fruquintinib, regorafenib, trifluridine plus tipiracil with bevacizumab. And then we'll come to the study, Breakwater. So this study was done in 2025. And in this study, so Beacon had looked at the BRAF inhibitors in the second line study. So in the Breakwater, they looked at BRAF inhibitors and moved it to first line therapy. So Breakwater was an open label, multi-center phase 3 study in first line BRAF V600 mutated colorectal carcinoma. Inclusion criteria was that these patients should not have received prior therapy in the metastatic setting. And of course, they should be BRAF mutated, have excellent performance status. Some key exclusion criteria was they should not have symptomatic brain met, so those patients were excluded. MSI high tumors were also excluded, as well as RAS mutated tumors were excluded. So there were 3 arms to this study, the encorafenib plus cetuximab, and then the encorafenib cetuximab with FOLFOX, and then the standard of care. And the there were two primary endpoints, the progression-free survival as well as the overall response rate. And then there were some secondary endpoints, overall survival, duration of response, median time to response, quality of life, and side effects. So the overall response rate was about 61% in the encorafenib plus the FOLFOX arm versus 40%. And the duration of response was about 14 months versus 12 months. And the benefit was seen across all subgroups, regardless of their age, regardless of how many organs were involved, regardless of the sidedness of tumor, and regardless of whether they had liver mets at the time of diagnosis or not. Overall survival, to me, this is what matters. So double overall survival seen in the encorafenib plus the FOLFOX arm, 30 months versus standard of care at 15 months. And again, the benefit was seen across all subgroups. So this now moved BRAF inhibitor, encorafenib, and cetuximab into the frontline setting. Side effect profile was pretty similar. Intestinal obstruction, fever, and anemia was seen more in the encorafenib with the chemotherapy arm, but overall side effect profile was pretty similar in all arms. 2026, there was an update to this trial, and this was just presented at ASCO GI in January. There was a cohort to the Breakwater trial, and that cohort had about 147 patients. In this cohort, instead of using FOLFOX, which was what it was in the original Breakwater trial, we then added FOLFIRI to this. So encorafenib cetuximab with FOLFIRI, as compared to just standard chemotherapy with bevacizumab. Same inclusion criteria, same exclusion criteria, randomized 1-to-1, overall response rate of 65% versus 39%, median time to response about 7 weeks. At 6 months, about 57% of these patients maintained a response versus 34%. The overall survival data is still immature, but I would expect that it would be similar to what we saw with FOLFOX. Side effect profile was also very similar. So what both of these studies show that the targeted therapy backbone is what matters. That is the key driver of better disease control in these BRAF mutated patients. Then we came to the COMMIT trial. So the COMMIT trial was initially a 3-arm study, but once, so this trial looked at atezolizumab monotherapy versus atezolizumab. So there's another immunotherapy, another immune checkpoint inhibitor versus in combination with chemotherapy. Initially 3 arms. The first arm, FOLFOX and bevacizumab, was removed because of they published the data from the keynote during this time, and which showed that pembrolizumab was highly efficacious in this MSI high tumors. And then they actually stopped accrual pretty early in March because of the results of the CheckMate trial. So then it was just atezo alone versus chemotherapy with atezolizumab. And this trial really tried to address those 29% of patients that progressed to, in the Keynote 177 in single agent and pembrolizumab. And a lot of these patients actually progressed within the first 12 months. Again, phase 3 randomized control trial, not a lot of patients, just 41 in this trial. They all had untreated MSI high disease, randomized 1:1. It did meet its primary endpoint of progression-free survival with an overall response rate of 86% versus 46%, of course, with more side effects. I think this data is still very immature. As I was listening to experts speak about this trial, it seems like this combination will probably be reserved for patients that cannot tolerate dual checkpoint inhibition with ipi/nivo, and you need more rapid tumor debulking. So adding chemotherapy with the immunotherapy in these patients, if they feel that they're not going to be able to tolerate dual immunotherapy, because that would be the first thing to do, or that would be the more preferred regimen. So we've made a lot of progress. There's been remarkable transformation. First started with just FOLFOX alone, showed a median OS of 6 months. Then we moved to 12 months. Now we're up to 30 months, even in those very poor prognosis patients with the BRAF mutated cancer, and in some patients even up to 95 months in those MSI high tumors. There's a lot of unmet needs in this space, specifically for those MSS stable tumors, which comprises majority of our metastatic colorectal cancers, about 85%. These tumors do not respond to immunotherapy, so we do need to find ways of sensitizing these tumors to immunotherapy, and that is the greatest unmet need in this space. 40% of colorectal cancers are RAS mutated, and we do not have effective targeted therapies for this space. 30% of them are right-sided. Again, these are just, more aggressive biology. Again, the 5-year OS is just about 20%. 5-year survival is 20%. So cure is still very rare in the metastatic cancer space. And then a lot of these targeted therapy, they do eventually develop, there is some resistance mechanism. So it really limits the durability of these agents. Where are we going from here? So being able to develop immunotherapy for those MSS stable tumors, bispecific antibodies, the use of ctDNA to measure residual disease, to monitor it, and then develop adaptive treatment strategies, as well as the use of antibody drug conjugates and expanding the indications in which we can use these drugs. Thank you.
Not that long ago, we really didn't do much surgery at all for patients with stage 4 cancer. We're still going to keep this nice and short, but we do have more options, and there are more patients that we treat aggressively now. So another thing that I was waiting, I thought for sure one of our first 3 speakers today would fess up to this, but I thought somebody has to be using AI for this, right? I mean, so I did. I used AI right away. And so I said, surgery in stage 4 colorectal cancer, and I wanted to see what it said. And so it came back with, well, surgery is mainly performed to alleviate symptoms or remove localized tumors in stage 4 colon cancer. Okay, maybe, yeah, partly right. Treating complications. Okay, so surgical intervention addresses complications such as bowel obstruction. That's a big one that we'll talk about. Or bleeding, maybe not as much, and to improve patient comfort. That is important, and we'll talk a little bit about that. And quality of life and treatment support. So obviously, like we just heard, the vast majority of patients with stage 4 cancer face kind of an incurable situation. And so we don't want to do something that is going to drastically decrease their quality of life, which is very, very important when we're kind of talking to these patients. So pretty good overall, I would say. Maybe not completely there yet, but pretty good. Okay, so how do we kind of assess these patients, and how do we go through counseling them and talking about what their surgical options may or may not be? Well, the first thing is, as Dr. Sharma just mentioned, is that we continually get new medical therapies, new interventional therapies, and the prognosis for patients with stage 4 colon cancer has improved significantly. As we get more and more immunotherapies and things like that, it continues to improve. And also, we're seeing younger and younger patients who are diagnosed with colorectal cancer, especially with advanced colorectal cancer. So just to put that in perspective, just about 2 weeks ago, I had a 27-year-old patient with stage 4 rectal cancer in my office. And so that's very, very different than somebody that is 85 years old, which is what we typically used to see maybe before more. And so we counsel those patients, and we talk to them about treatment and treatment options very differently. Obviously, younger patients, we have more options. We're going to treat more aggressively. But one of the first things that we do is we kind of look overall at their burden of disease. And so Dr. Sharma mentioned kind of oligometastatic disease. And it's always interesting how that is defined. Sometimes we talk about that as an isolated metastatic implant someplace, either in the lungs, like Dr. Wells was talking about, or in the liver. Sometimes we'll define it as up to 5 separate sites. And it's very, very different depending, like, for example, if it's in the liver, if it's all in one side, if it's in both sides, how resectable it is, how treatable. All those things kind of factor into the decision about what we may and may not be able to offer these patients. The big things that we want to avoid when we're talking to patients about surgery in stage 4 cancer is, especially if they're presenting with their initial diagnosis, we do not want to delay their initiation of chemotherapy. That is by far the most important thing that they need. We want to get them to chemotherapy as quickly as possible. There are situations that happen relatively frequently, I would say, where somebody presents with an advanced aggressive cancer and has an impending large bowel obstruction, which is one of the things we'll talk about a little bit later. Large bowel obstruction and small bowel obstruction are very, very different. The reason is the vast majority of patients have a competent ileocecal valve. So when we eat, food goes to the stomach, small intestine, through the ileocecal valve and into the colon. The problem with the large bowel obstruction is if you get a mass in the colon or the rectum that is going to obstruct, everything backs up above that, and then things cannot get back through the ileocecal valve, so you get what's called a closed loop bowel obstruction. So the colon just keeps getting bigger and bigger and bigger and will perforate. And so that is something that we have to treat typically before we get them to chemotherapy so that they do not develop any complications in the midst of their chemotherapy, which is obviously hugely problematic if you have somebody that now you have to do emergency surgery or an emergency intervention on in the middle of their chemotherapy. That is not the situation that we want to find ourselves in. So first principle, get them to chemo as quickly as possible. If we have to talk about a bowel obstruction, figure out if we're going to do a stent, colonic stent, or a colostomy. We'll talk about both of those in a little bit. Don't do things that are going to significantly decrease their long-term quality of life, and obviously try to avoid surgeries that are going to significantly decrease their quantity of life or increase their suffering. Okay, so as I just mentioned a little bit, very, very different in terms of how patients will present with stage 4 colorectal cancer. Widely disseminated disease where patients have multiple lesions throughout their liver. Most of us have seen CT scans where it's hard to even tell what the normal liver is because there's so much cancer in the liver that there's barely any liver tissue remaining. That is very, very different than somebody that's presenting and has one isolated liver lesion peripherally in the liver somewhere, one isolated lung lesion that's easily treatable surgically as well. That's the first thing that we need to do, decide which of those two things we're dealing with and if they're resectable at some point in time or not. Because again, if somebody has a massive rectal cancer, it's involving their pelvic sidewall, it's involving the blood vessels and the nerves that go to their legs, that's somebody that's not going to be a resectable candidate. So that conversation is different than somebody that may have these. Also very important, and Dr. Sharma kind of talked about this, so I won't spend too much time about this, is when they are diagnosed. And so is there metastatic disease present at the time of their initial diagnosis? Or is it somebody that maybe we've done surgery on and may or may not have had chemotherapy, and then 3 years from now they develop metastatic disease? Those are different situations as well. Okay, so I'm going to spend most of the time from here on out talking about those patients with oligometastatic disease, or just a few metastatic tumor sites that we think may be patients that we can treat curatively with surgery. Now, curatively, it's very, very important when we talk to these patients. That does not mean like, oh yeah, we're going to do this, you're going to get chemo, we're going to do surgery here, we're going to do surgery there, and then like you should expect to be cured. That is not the conversation that we have. The quote unquote cure rates, even for highly selected patients, are still unfortunately relatively low. So we're still kind of talking about in that 25% range, but obviously much, much better than 0%. And again, if we're talking about a lot of young people with aggressive disease, that can make all the difference. How do we treat these patients? Like we talked about, the first thing we need to do is we need to get them to their treatment, chemotherapy, immunotherapy, see how they respond, restage them, see if their disease blossoms and spreads to other places. Obviously, at that point in time, that's not a situation that we'd be talking about surgery, or if they have a very, very good response. And if they have a very, very good response, those are patients that we can start talking more aggressively about surgery. A lot of these operations, unfortunately, are relatively significant operations, both in terms of the operation on the colon and or the rectum and the liver and or the lungs. And so, like we mentioned before, there's a big difference between doing a segmentectomy for a isolated lung tumor and somebody that's going to need a pneumonectomy or their whole lung taken out. There's a big difference between doing a wedge resection in the liver and doing partial hepatectomy. Those are very, very different surgeries. And depending on what we're talking about, we talk about doing the surgeries at the same time or doing them in the staged fashion. And so there's some sort of debate. For instance, if you have a patient with colon cancer and liver lesions, which surgery should ultimately go first, colon or liver? We will try to do them at the same time if we can. Typically, what we'll do if we cannot do that is if the colon lesion is not overly symptomatic, meaning they're not bleeding from it or not going to nearly obstruct, we'll address the liver first and then do the colon or the rectum. This works very, very well, especially in patients with rectal cancer, because those patients typically will have gotten their systemic therapy. If they've had a good response, then we give them chemoradiation therapy. And so then from a rectal cancer surgery standpoint, we want to wait 8 to 12 weeks after they finish their radiation therapy before we do their low anterior resection or their abdominal perineal resection. And that gives the liver surgeons or the lung surgeons a great kind of window to do their surgery, let the patient recover, and then do our surgery. Okay, so obstruction, like we talked about, this is a major issue. And I think one of the things that unfortunately sometimes kind of gets missed for patients and becomes a really, really big issue. When we see patients and we evaluate them for their tumor, regardless of if it is metastatic or not, we'll typically look at their colonoscopy report, or if it's a low tumor, we will usually do a flexible sigmoidoscopy. We look at the size of the tumor and we see if we can pass the scope, an adult size colonoscope, easily through that tumor. The reason we do that is because when patients start their treatment, that tumor either A, can swell, or B, may not respond for a period of time. If that happens and that obstructs, now we got a big situation. And so if we cannot kind of easily pass the scope through there, then we talk to those patients about doing something before they start their systemic therapy to avoid the situation where they're getting systemic treatment and now have a surgical emergency. Essentially, we have two options. One option is colonic stenting, and one option is a colostomy, right? Clearly, no patients want to have a colostomy. That is not high on anybody's list. How we generally approach this is colonic stents are great at certain locations in the colon. They are not very good in the rectum. They are good for short-term relief. They have increasing levels of complications with the further you go from when the stent was placed. And so if these are patients at their initial diagnosis that we expect are going to be treated for quite some time, your risk of having a stent-related complication, including a bowel perforation, is high long-term in those patients, okay? And then we're back to that situation where we're kind of having to do an emergency operation in somebody that's probably in the middle of doing their systemic treatment. Typically, those are the patients that we will counsel about a colostomy. Colostomies almost always can just be done minimally invasively. Those patients typically spend just a couple nights in the hospital, and then I usually let them start their chemotherapy about 2 weeks later. So it does not delay their treatment. And then you know they're safe, they're not going to have any big problems. The medical oncologist knows that they're safe and they can get treated as aggressively as they can tolerate at that point in time. The other issue with stenting, again, as Dr. Sharma mentioned, is that quite a few of these patients end up on a treatment called Avastin, bevacizumab, that is notorious for causing bowel-related issues, including perforation. So we're cautious of that and careful in our recommendations of stoma creation versus stenting as well. Why don't we stent patients in the rectum? Sometimes we get asked about that. Well, you have that acute sort of rectosigmoid junction there, which becomes very problematic. If you put a stent in there, they have a lot of tenesmus and a lot of pain. So that's not something that we typically will do. sometimes we see patients in the hospital that are admitted and they're clearly sort of nearing the end. Maybe their treatment hasn't been as effective. Maybe their disease has just taken over. Maybe they can't tolerate further treatment. Maybe they haven't been diagnosed yet. Sometimes these patients have large bowel obstruction as well. Often these are patients that the palliative care team is kind of talking to them about what their goals of care are. Typically, if we have patients that either they cannot have further systemic therapy or they do not want to have further systemic therapy, we don't do much of anything from a surgical standpoint. This, I would say, is one of those instances where I will offer to counsel them to have a colostomy placed. And the reason is a large bowel obstruction, especially dying from a large bowel obstruction, is painful, causes death through obstruction, perforation, sepsis. Even our best sort of treatments that we have in terms of palliation do not completely get rid of those symptoms. And so those are patients that we'll think about creating a colostomy for them so that they can then transition to hospice if that is indeed their wish. And like we mentioned a little bit earlier, I think that one of the main reasons to consider being aggressive in patients, especially with oligometastatic disease, even if it seems like maybe we're not at a situation that it is highly likely they will be cured now, we don't know what's going to be coming down the pipeline. And so, again, kind of going back to these young patients who are very, very healthy, who have relatively limited stage 4 disease, we try to do whatever we can from a treatment paradigm safely to treat them as aggressively as possible. And who knows, maybe in several years we have another big trial, we have more medications out. But I think it would be fair to say, and I'm sure most of my partners will agree, that all of us have patients at this point in time who have been diagnosed with stage 4 colorectal cancer that are alive many, many years after their initial treatment, and in some cases, even quote unquote, cured at this point in time. So it does not happen often, but we have to stratify those patients appropriately. We have to know who we're going to treat aggressively and who maybe we're not going to be able to help. And we have to help them make that decision. I think one of the big things that we notice from our standpoint is it is hard for a palliative care provider, hospice provider, non-surgeon to have kind of a discussion with a patient about why they may or may not be a candidate for surgery. And so I think it's always not only appropriate, but always super helpful for these patients to meet with a surgeon so that we can kind of talk to them about what they're facing, what surgery would look like, what recovery would look like, and why we recommend what we're ultimately recommending. These are a couple references here.
Hello, everyone. I'm Amanda. I'm the current clinical colon and rectal fellow. I can tell you my lectures can be very quick. It's very uncomfortable. No one wants to talk about it. Not as interesting as the ones that we have coming up, especially the last one, but we'll get through this. So an itchy anus, the Latin term is pruritus ani, and affects 2 to 5% of the general population, but it's very, very likely underreported, because if you have an itchy butt, you just think it will go away and you don't want to tell anyone about it. But then you start seeking treatment when you have it as very persistent. So it is most common in the 4th to 6th decades of life, and especially in males. The urge to itch is mediated by the unmyelinated C fibers. And there's this thing called the vicious cycle of pruritus ani. It's an itch, scratch, itch cycle. So the unmyelinated C fibers, they're stimulated in the perianal skin. Scratching worsens it, and then you get excoriation and cutaneous injury to the anoderm. And again, that stimulates the unmyelinated C fibers, and then you keep going back and forth, back and forth. In about 75% of these cases, an underlying cause can be identified, and that's the term for that is a secondary pruritus ani, and the rest is considered idiopathic. This is just a very large table of all the things that can cause an itchy anus, and they're categorized, and we'll go over each category in a little bit more detail afterwards. So when you have someone that comes to you with an itchy anus, you should always ask questions and always look at their butt. In terms of history, you can identify a causative factor. You should ask about risk factors the patient has, their bowel habits, how are their bowel movements? Is it very loose? How often do they go? Do they keep wiping and wiping and wiping until the toilet paper is essentially without any brown stool on it? The duration of the symptoms they've had an itchy anus, their hygiene, and their medical and sexual history. Other things you can ask about are new products they've used, things that they like to wear potentially. And on physical exam, if you are looking and you're concerned for malignancy, you should always obtain a biopsy. You should perform an anoscopy to evaluate the anal canal and the distal rectum. And if you're concerned for an infectious cause, you should always obtain a swab for virology or microbiology, and those are very simple and easy to do. It's almost like a nasal swab, but for the other end. Different causes, fecal soilage or diarrhea, that's the most common cause of why patients have pruritus ani. They believe the anus is not getting clean enough and then they overwipe. Feces is both an irritant and an allergen. And there are also many anorectal conditions such as hemorrhoids, prolapse, fissures, abscesses, fistulas that can cause that change kind of the surface area of the perianal skin, and it can contribute to fecal soilage where they feel like they're not cleaning themselves well in those different folds or tissue. Certain foods or medications can also cause it. It is unclear if it's a mild allergy to the food or the breakdown products of the food, or if it's a direct exposure of the skin to, again, the breakdown products. Patients can try eliminating different things for 2 weeks, and certain ones that have been talked about that cause pruritus ani are on the table. So things like coffee, tea, milk products, citrus, beer, wine, alcohol, tobacco products, tomato products. And if they don't have any improvement, it's not likely the cause of pruritus ani. There are many dermatological conditions that can cause an itchy anus, and these are ones that can affect anywhere in the body that causes itching there. So things like contact dermatitis, atopic dermatitis, eczema, psoriasis, hidradenitis, and then you can get infections as well. So the bottom picture is a fungal infection, which is present in about 10 to 15% of cases. You see erythematous plaques and satellite lesions. And then there's such things as pinworms, which is not really prevalent in the adult population, but it affects the pediatric population. And you can do the tape test where you put a piece of tape on their anus and then at night the worms kind of attach to it. So the treatment, for the first time you see them when they're actually seeking treatment, you want to break the itch, scratch, itch cycle. You want to improve their anal hygiene. You can tell them they can do sitz baths and use bidets now to keep the skin area clean. Avoid excessive wiping because then you'll stop the trauma to the perianal skin, which is so sensitive. You can apply cornstarch powder to keep the area dry. Can use a barrier ointment overnight. And again, wear loose fitting clothing. Educate them on food education, like the ones that were mentioned in the table. They can try eliminating it, but that's very difficult for a lot of people. So they may not do that. And then if you can find on history things that are causing the itching, like a new detergent, a new soap with fragrance or something of that sort, have them stop using that as well. You want to improve bowel habits, recommend a high fiber diet so that it can bulk up their stools, especially if it's loose. Increase water intake, 64 ounces, and then they may or may not need some antidiarrheals like Imodium to slow down their bowel movements and then so that their perianal skin will heal. And just doing all of this or most of this is effective in up to 90% of patients in treating their itchy anus. But what happens to those patients who have persistent symptoms 3 to 6 weeks later and they tried all of that, it doesn't work? Likely at that point, it'll be your second encounter with them. And then you can consider a biopsy or an endoscopy to rule out other underlying causes. You can try a low potency steroid cream, so that's 1% hydrocortisone or even a higher concentration 0.05% clobetasol for 2 weeks, but no more than 8 weeks because it does thin the skin significantly for an extended period of time. They can try systemic antihistamines because if potentially it's a systemic cause, it will help with the itching. And then for refractory cases, there's topical capsaicin, which is a derivative of chili peppers, which, as you can tell, causes an inhibitory feedback because then it burns and you wouldn't want to scratch your anus at that point. Then there's topical tacrolimus, which is 0.1% formulation. If it still doesn't work, it's a very strong immunosuppressant that will, again, help with the itching. And then the very, very last resort is anal tattooing with methylene blue, which I'll show you a picture of. The methylene blue is toxic to the nerves that supply the perianal skin. The tattoo disappears after 3 to 4 weeks. But a big thing is, I mean, aside from if they have an allergic reaction to the methylene blue, is it can cause skin necrosis. And I think that would probably be a worse outcome having a necrotic anus versus an itchy one. And this is just a flow sheet of everything. When the patient presents, you want to evaluate them. You do a history and physical exam. Again, that will help you identify a lot of the time what's causing this. You may want to do an endoscopy with biopsy and endoscopy. If you can find a causative factor, again, that goes into the secondary pruritus ani on the right side of this, I guess the left side. And then if you can't find out what's causing it, it's called idiopathic. So for the idiopathic, you try to do all those things for the first encounter, improving their hygiene, removing potential agents, improving bowel habits, and you may or may not give them a low potency topical steroid. If it's the secondary pruritus ani and you can find causes, infectious, dermatologic, systemic disease like diabetes or liver disease, local irritants, or the colorectal, anorectal disorders, you treat them specifically targeting those and then have them come back and see if the symptoms resolve. If they do, you just watch it and great, they probably won't come back. But then if they don't resolve, then it's refractory. You want to repeat your evaluation because maybe the initial evaluation wasn't the causative factor and you're trying to find something else that may cause it. And then you go through this whole flow sheet again. And if again, it's refractory, then you can consider the anal tattooing, topical tacrolimus, or the capsaicin.
Infections, yep, you guessed it. STDs of the anus and rectum. It happens, and it's a bad day for everyone. So, anorectal immunology, the anus, the rectum, just like the rest of the GI tract, there's several layers to the walls. The mucosal layer acts as a physical and immune barrier for protection against bacteria and viruses. That way, we don't absorb these infections. We don't. That's why we're not getting sick all the time. Bacteria is going through our anal rectal junction all the time when we go to the bathroom. We're not often getting sick. It is for this reason. Now, abrasive force causes destruction to the mucosal layer. So if there's tears or something like that, that'll allow bacteria and viruses access to the circulatory system. So that's why we're not always getting sick, but it does happen. You can have bacterial infections. So chlamydia, lymphogranulovenereum, gonorrhea, syphilis, chancroid, donovanosis. Maybe you've heard of some of these, maybe you haven't. Hopefully you never do. Incidents, 2.2 million reported bacterial STIs in 2024, but there's probably a lot more that just go unreported or someone seeks treatment, that urgent care or something. So it's likely much higher than this. Reported cases declined about 9% from 23, but we're still 13% higher compared to a decade ago. But it's, like I said, it's hard to know the true incidence of these. Bottom line, although it seems like the incidence is decreasing in recent years, there's still a substantial number of new cases that are reported and probably much more that aren't. If you have any Friends fans here, remember the episode where Joey, his pictures were used without his consent or without his knowledge for STD campaign. So that would be rough. Transmission, like you'd expect, unprotected vaginal, anal, or oral sex. And there can be vertical transmission to neonates in childbirth, and often co-infected with other STIs. If you find one, you generally have to test for a whole bunch of them. Rectal disease acquired via anal receptive intercourse or spread from genital disease. So it's not always, and people are very surprised sometimes we diagnose some of this stuff in clinic and they're just like, I swear that is just an exit only back there. And say, well, that you can still get it, don't worry. I am not thinking any less of you. So some of these, like there's chlamydia, the most common STI in the US, over 1.5 million cases reported in 2024. Again, it's a 4% reduction in reported cases over the last 5 years and 8% reduction over 1 year. So hopefully we're seeing less of it, and hopefully that trend continues. It's from the chlamydia trachomatis bacterium. Incubation period is several days to 3 weeks after contact. So oftentimes someone can be infected and not know it, and in that time you can't spread it. So there's some wonderful pictures, unfortunately. Everyone's least favorite part of this talk. Chlamydia often asymptomatic. In neonates, you can see conjunctivitis. In males, urethra is most commonly affected. So there's drainage, painful urination. You can get swelling, pain and swelling, testicular pain and swelling. In females, the urethra and cervix are most commonly affected. You can get discharge, you can get bleeding, you can cause pelvic inflammatory disease. And then rectal disease, just significant rectal pain. You can get bleeding, you can get discharge, mucus discharge, things like that. Here's some wonderful pictures that Dr. Dan provided for us. The diagnosis, the nucleic acid amplification test of urine samples or vaginal swabs. Then there's a specialized assay for rectal samples and rectal swabs. So essentially, we'll see someone in clinic and they're having significant rectal pain, bleeding. We go through the standard test, rectal exam, and oftentimes in clinic, we can do a proctoscopy and you'll see significant inflammation. And so you ask other questions if it looks like it, or high risk population, something like that, anal receptive intercourse, then you kind of have this higher on your differential a little bit sooner. So you have to take some swabs, or since we work so closely with infectious disease, we can often get them in with some of our wonderful ID docs so they can run the whole gamut of tests and then decide on treatment from there. Treatment, it's empiric treatment against gonorrhea and then co-infection, herpes simplex virus. It's azithromycin 1 milligram orally once, or doxycycline twice a day for 7 days. Doxy is more effective against chlamydia, and then they retest 3 months later, make sure things are cleared out. And then lymphogranuloma venereum, also some more wonderful pictures. Incidence is higher in men of sex with men population and in HIV positive individuals. And these individuals are also more at risk for co-infections. So same thing. When you see one, you kind of have to test them all. It's caused by a more aggressive type of chlamydia trachomatis, and presentation can mimic IBD. In the colon and the rectum, it can look like ulcerative colitis or Crohn's disease. You can have severe proctitis with ulcers, leads to abscesses, fistulas, strictures, lymphadenopathy. So it's not the most obvious thing, but you have to have it. You could really be thinking IBD, some sort of colitis like that. But if you don't have this on your differential, you're going to miss it. So the patient's going to get sick, and you really have to think about this sooner rather than later in certain populations. Again, the diagnosis, the nucleic acid amplification test for chlamydia, and then cultures for lymphogranuloma. Again, the treatment, doxycycline, BID, this one's for 21 days. A lot of the treatments are going to be the same. Medications are effective for a lot of them. It's just you give them for different amount of times, different doses, and oftentimes you just treat all of them together just in case. You see some of those pictures with the ulcers. I mean, some of that can look, you can see it and wonder, is this IBD, is this UC, is it even cancer sometimes, but it's one of these infections instead. Gonorrhea, that's the second most common STI in the US, over 500,000 cases in 2024, almost a 20% reduction in the last 5 years, almost a 10% reduction in the last 1 year. It's from the Neisseria gonorrhea bacterium. And there's increased antibiotic resistance for this one as compared to other STIs. And here the incubation period is about 2 weeks after contact. So again, a lot of folks may not know they're infected for quite a while. It's a lot of time to potentially spread it. Again, often asymptomatic, especially at the beginning. In males, the urethra is most commonly affected, painful urination, thick discharge, and not as much testicular pain as common as the others. In females, the cervix, urethra, and the rectum commonly affected. And again, thick, purulent drainage. They can have Bartholin gland abscesses, and like chlamydia, it can also cause pelvic inflammatory disease. And again, rectal disease is tenesmus, so really bad spasms, hematochezia, so bloody bowel movements, and a lot of mucus discharge, abscesses, things like that. Again, more just terrible pictures, but there they are. Diagnosis, the anoscopy in clinic, when we do that, we show very friable, very inflamed erythematous mucosa, really thick discharge. Same thing, the nucleic acid amplification testing, gram stain cultures, and then the treatment, because of the antibiotic resistance, it's a little bit different. You can do ceftriaxone, IM injection, or azithromycin, 1 gram. And you retest again after 3 months. And this is one where you probably would treat for chlamydia as well at the same time. Again, co-infection being so high. There's syphilis, over 190,000 cases reported in 2024. Again, that also seems to be decreasing over the last 5 years and last 1 year. It's from the treponema pallidum spirochete, and there's 3 stages of infection: primary, secondary, and tertiary. This one we see a little, obviously less often than the others, but still something we have to think about in high-risk populations. Incubation period, 1 to 3 weeks after contact. The secondary infection could be weeks to months, and tertiary even years. This is where having a good ID practice that you work with really comes in handy, because it'd be tough for us to follow this and treat all stages. Primary syphilis, most often asymptomatic in HIV positive patients, very at-risk population. Painless genital ulcers, and painful extragenital ulcers, and the ulcers can resolve spontaneously. Secondary syphilis, you get some systemic symptoms: fever, malaise, joint pain, diffuse lymphadenopathy. Sometimes they can present with like rectal mass and rashes on their hands and feet. And then failure to treat this stage can result in progression to late and asymptomatic stage before tertiary. And tertiary occurs in a minority of patients, but then very sick, cardiac involvement. Neurosyphilis, like meningitis, cranial nerve palsies, paralysis, dementia, that can occur at any stage, and that's increased with patients with HIV. So syphilis, folks can get very, very sick. Diagnosis, screening test for venereal disease, rapid plasma reagent, and then confirmatory antibody testing for all positive screening tests. Again, some of those pictures with the fat ulcers, it's tough to look at that and, not knowing anything about the patient right away say, oh yeah, that's probably syphilis. So you really have to have a high index of suspicion here. Treatment, single IM dose of penicillin G. You can get some reactions within 24 hours of treatment with myalgia, fever, headache, preterm labor in pregnant women, of course. And then you retest at 6 to 12 months. It's important to make sure, that you have cleared these things. Screening and prevention, well, for chlamydia and gonorrhea, for sexually active women under the age of 25, sexually active women over 25, if increased risk. And then in pregnant women, and then all sexually active men who have sex with men annually, or every 6 months if even increased risk beyond that, and all HIV positive patients annually. For syphilis screening, pregnant women, all sexually active men who have sex with men, and then all HIV positive patients. So just certain higher risk populations. And then prevention, safe sex practices and abstinence for at least 1 week following completion of treatment. And that's something that a lot of counseling, that's also where the ID docs really come in handy. Chancroid, not common in the US, more likely to occur in regions of Africa and the Caribbean. So I can't say that I've ever seen this. Caused by Haemophilus ducreyi bacterium. The incubation period is a few hours to days. Presents as painful papule that progress to painful ulcers. Sometimes lymphadenopathy. Diagnosis, just clinical exams. It's difficult to culture. And then treatment, ceftriaxone IM or azithromycin. And then donovanosis, again, very rare in the US, also not something I've seen. Definitely not very common here, more likely to occur in tropical and developing areas, South America, South Africa, caused by Klebsiella granulomatosis, and presents as non-tender, red, bleeding genital ulcers, anal rectal ulcers, and deep fissures. And diagnosis, Donovan bodies on a gym stain. Again, thank God for ID, because I wouldn't be able to do this or have to look it up every time. You know, treatment, azithromycin, 1 gram orally once a week for 3 weeks, or 500 milligrams daily for 3 weeks. And then there's viral STIs, herpes, HPV, and HIV. Herpes, one of the most prevalent STIs in the U.S. Over 20% of adults carry some type. It's caused by DNA virus family. There's oral lesions or HSV1, and genital lesions or HSV2, but can be HSV1 as well. And transmission, vaginal, anal, or oral sexual contact. Incubation period for 21 days. The primary infection, prodrome, fever, chills, malaise, so very vague symptoms. For a genital infection, you get severe anogenital pain, followed by development of vesicles. When I've seen this, and they're in a lot of pain, a lot of like really bad perineal pain, and you see these ulcers, you can hardly touch them. And so then it's important to get on that early and send them to ID, and almost even start empiric treatment, because it's a very, very painful thing. And so that's a rough one, because they're already in a lot of pain, and then you tell them, hey, I think you have herpes. That's a tough clinic visit. I'll tell you, you need more than 15 minutes for that one. Now, lesions are highly contagious until epithelial barrier forms, so until they start to heal. In the latent phase, after the primary infection, the virus travels retrograde along sensory nerves and remains dormant, and then it can be reactivated at times down the road of times of high stress and things like that. Recurrent infections, they won't have the prodrome phase, and then the symptoms are like less severe and last a shorter amount of time. Diagnosis, there's cultures, staining of sores, the serologic testing on endoscopy, very friable inflamed mucosa, ulcerations, usually in the very distal rectum. So oftentimes we can see this in clinic, anoscopy and proctoscopy. Treatment for primary infection, there's acyclovir for 7 to 10 days, or valacyclovir for 7 to 10 days, and then recurrent infections, same meds, just for higher doses or longer period of time. Treatment for HIV positive patients, sometimes they need the suppressive antivirals. And then HPV is like one of the most prevalent. This one you really have to counsel folks that when they show up with anal warts or condyloma, and everyone is just shocked that they have it, and how could they? And I've been married for 30 years. Like, okay, well, it's just very prevalent in society. It's okay. It doesn't mean anything bad about you. This one takes a lot of counseling. It promotes uncontrolled cell growth and is associated with development of oropharyngeal, anal, vulvar, vaginal, cervical, and penile cancers. Transmission, vaginal, anal, oral sexual contact, close skin-to-skin contact. It can be transmitted even if no visible disease. Anorectal disease can result in continued spread from genital disease. And again, incubation period is up to 3 months. These are some of the pictures of people having it on their tongue, and obviously the anorectal involvement, giant condylomas. Treatment for genital, you see those growths, like cauliflower-like growths is an unfortunate way to describe that, but cauliflower-like growth that cause bleeding, itching, difficulty with hygiene. That's usually what gets patients in to see us. We do high resolution anoscopy. We use acetic acid to kind of stain to see if there's some lesions that are smaller than you can see with the naked eye. Treatment goal to remove all visible disease and spare as much healthy appearing tissue. And then there's topical agents that you can give after you remove all of like that disease that we could see in clinic. So there's imiquimod cream and others. Surgical excision, often in the operating room, obviously very sensitive area. And you just basically take as much as you can without causing too much scarring and stricturing and things like that. And then sometimes like that one at the bottom, thankfully we don't see things like that very often, the giant condyloma. You do wide local excision, try your best to get good margins. Some of these will present like this, and pathology will tell you there was a cancer already in it, a squamous cell cancer or something like that. Oftentimes when something like that shows up with circumferential involvement, we can't even remove it all at once. Sometimes you have to stage things, take some from one side, take one from the other. So you really have to explain to patients this is going to take a long time to treat. It's going to take multiple operations. I'm going to have to see in surveillance. We need to keep it up and make sure things don't come back and never have a chance to become cancer. So according to CDC, vaccination can prevent over 90% of cancers caused by HPV. The current guidelines recommended for all 11 to 12-year-old children to receive 2 doses of the HPV vaccine. 6 to 12 months apart. And it can be given through age 26. And then reduction in infection and cancer rates within 12 years. HPV infections decreased 88% among 14 to 19-year-olds and 81% for 20 to 24-year-olds. Incidence of HPV-related cervical lesions reduced by 40% in vaccinated women since vaccine introduction. So this is another one where you talk to ID and even the PCPs, and if they're in the right age range, definitely recommend vaccines for everyone. And even if you might be past it, if you're in a group who might be exposed to this a lot. I know a lot of our head and neck surgeons have gotten these, both at our group at the Med Center. Just if you're going to be around this type of thing, it's a good idea to talk to your doctor about the vaccine. And then HIV, according to the WHO, incidence of HIV is reduced by 40% and deaths by 54% from 2010 to 2014. It's caused by a retrovirus that incorporates into the human genome and destroys T cells. Those are important immune cells to help fight infections. Transmission is oral, rectal, vaginal, penile contact with infected fluid, and also can be direct injection to bloodstream. There's 3 phases of the infection: the acute phase, the flu-like symptoms, that happens a few weeks after infection. The dormancy phase, as viral replication and CD4 counts begin to fall, that can last several years. Once the CD4 counts are less than 500, then you're considered immunocompromised and you're at increased risk for other infections like HSV and HPV. And then you get a diagnosis of AIDS once the CD4 count is below 200. You have increased risk of those significant opportunistic infections and AIDS defining illnesses like CMV and pneumocystis and things like that. So benign anal rectal pathology is the most common anal rectal manifestation in HIV positive patients. So we see ulcers, hemorrhoids, things like that, but they're particularly painful and they're very hard to treat. And we have to start thinking about it in more vulnerable populations. If they show up with like a fissure that is just not getting better with like our standard treatment, you have to think about this earlier rather than later, because then you end up treating for a benign thing and missing one of these diagnoses. Diagnosis, serological testing, and then treatment is really just to control the HIV. Essentially, is how you treat any of these issues. So highly active antiretroviral therapy. And the HIV positive patients who are receiving HAART are at no increased risk for complications following anal rectal procedures. So, someone with HIV and it's well controlled in their own heart and they show up with a typical fissure, or they show up with typical hemorrhoids and they need a procedure, you should be able to take care of that as long as the HIV is well controlled. Screening, everyone between ages 13 and 64 should be screened for HIV at least once in their lifetime. And then it goes up from there depending on other risk factors, essentially. And prevention is safe sex practices. And then a lot of information here for free, low-cost STD testing in the Omaha area. And that should be about it.
This talks about rectal foreign bodies. So a couple things that we're going to talk about today. We'll first discuss the care for the patients with rectal foreign bodies, and then I'll talk about some tips and tricks and how to manage the patients from a humanistic perspective. And then I'll present an algorithm for the treatment of the patients with rectal foreign bodies. So one of the first points is that a lot of these patients, they're not excited to come to the emergency department with this foreign body, right? And as a demonstration of that, I'll present a story that I did not directly encounter at fellowship, but there was a guy from the Bayou down in Louisiana who had placed a foreign body in his anus and rectum, and it was a toilet scrub brush, and it was the scrub brush portion first, and he couldn't get it out, and he was certainly very embarrassed about how it got there and what was there. He did not want to reach out to anybody to drive him to the emergency department. He didn't want to call an ambulance to take him there. So he decided to drive himself. But if he was going to drive himself, he's got this scrub brush sticking out of his bottom. So he wasn't going to comfortably be able to sit in his car and drive himself. So he ended up taking a hacksaw to the handle and cutting off the handle, which then allowed him to sit in his driver's seat and drive him to the emergency department. So that's just a demonstration of the lengths that people may go to avoid the embarrassment, having to look somebody in the eye and say, I've got a scrub brush on my butt. And I don't know, I don't want to speak for my partners and what their experiences have been, but when I have had to deal with patients with rectal foreign bodies, a lot of times they're coming to the emergency department late at night, probably to avoid a busy emergency department. And so, just recognize going in that nobody is excited about this sort of thing. Patients may also present a really convoluted history about how something may have gotten up there in the first place. So it's important, given the embarrassment, to be kind, kind of stick to just the important pieces of information. What is there? How long has it been there? Remain objective, and also recognize that there are occasions when these were not necessarily placed there by the patients. Somebody may be the victim of sexual abuse, and this may have been placed there against their will. So keep in mind that that may be going on as well. So briefly, here's the algorithm, and we'll kind of walk through this throughout the talk. To some extent, there's a little bit of voyeurism, medical voyeurism with this. This always gets people excited. People are always super pumped to share pictures. And I want pictures of things that they may have encountered. I want to encourage you to not do that. These are not photos of patients that I have actually taken care of. These are all photos that are readily accessible on the internet. But because this sort of thing gets people laughing and excited, we'll just play a little bit of a game. What is the object?
Gun.
This is a gun, okay. What is this object?
Like oh, the hand thingy. Electric. No, the.
Oh,
the
frother.
Somebody said it.
Oh.
Electric toothbrush. I think here are are we able to turn down the lights? But another key point we talked about earlier is discretion is super important. Don't go sharing pictures of this around. I think Hernan may remember this, but when he and I matched into fellowship, we were on a group chat with all of the other people who matched at the same time, and we found out that somebody had matched and then had their match revoked because they were not able to graduate from the residency program because they had been sharing photos of a rectal foreign body that they had encountered. So, I mean, for the sake of the patient, don't share information. For the sake of yourself, don't share information. Anybody recognize what this may be? Dentures, yep, nice. Okay, now we're able to see it a whole lot better. It's always a little surprising. Yeah, to infinity and beyond. I think the wings, I couldn't tell whether the wings were down or up.
Yeah.
I'd be uncomfortable if they were out. So more key points. So after you have obtained the history and found out that the patient has this foreign body in the rectum, it's important to know a couple of other things. So does the patient have symptoms of peritonitis? Are they demonstrating signs of peritonitis? Do they have a rigid abdomen? That would suggest that this lesion or this thing in their rectum has caused some sort of perforation, and they may require an emergent operation. Another question is this thing palpable? If you perform a digital rectal exam, can you feel this thing? Is it low enough that you can maybe get to it with just your fingers or with an instrument at bedside? Or is it far enough up there that you're going to need to take the patient to the OR for either an endoscopic removal or an X-lab? Do you know what this is?
Candle.
Yeah, according to Google, this is an instant coffee jar. I don't know what these little pins are here, but yeah, apparently it's a coffee jar. Another key point is that the patient's physical comfort should always be assured. So, in keeping in mind that this is going to be an embarrassing problem, you should ask them before trying to remove this if they would be okay with you trying to remove it, or if they would be most comfortable removing it while you're asleep in the OR. How about this thing?
Spray paint.
Yep, it's a spray deodorant can. I don't know why radiology decided to point this out. I mean, it seems pretty straightforward what it is. But just some tricks for the toolbox. Whenever I have removed something at bedside in the emergency department, if I can feel it, I have the patients do a Valsalva maneuver. So I have them bear down, which if it's just at the tip of my finger, and I've got pretty long fingers, if it's just at the tip of my finger, a Valsalva maneuver or having them bear down will bring it a little bit lower so I can potentially get my fingers around it and grab it. Another approach that can sometimes be used is to slide a Foley catheter up there. To some extent, when something gets stuck up there, there's almost like a vacuum effect and it gets like stuck up there. And if by putting a Foley catheter up there, you can almost kind of break the seal of that vacuum, which may allow you to get it a little bit better. And then sometimes you can place like ringed forceps up there and grab it. I remember from residency being in the ER with Dr. Shashi and removing a foreign body using forceps. Dr. Shashi was not the patient. Yeah. Anybody recognize this?
Medela.
Okay, yeah, I heard it. Some more key points. It's important to know the anatomy of the patient and also recognize the anatomy of the foreign body. You want to know kind of going in, how big is this thing? What is it impinging on? What is the extent of it? How big of this thing should I expect to pull out? And that will kind of sometimes dictate whether an endoscopic evaluation is required. Because this thing that's sitting there, you can kind of tell here, it's not coming out because it's sitting right at the coccyx. And we don't know how long it's been there, but if it's been there for a long time, it may be causing some sort of pressure necrosis or something like that that could compromise the integrity of the bowel and may necessitate or may be worth evaluating endoscopically after this thing is removed. So if you're able to successfully remove this thing transanally, there are a couple of things that are important. There's the potential for a delayed perforation if this thing, especially if this thing has been there for a while, because it can cause some pressure necrosis. And so sometimes you want to observe the patient with serial abdominal exams in the hospital for the period of 24 hours or so. Sometimes patients, again, are super embarrassed and just want to get the hell out of the hospital and not stick around for very long. And so in those situations, it may be valuable to perform an endoscopic evaluation just to look for pressure necrosis or signs of ischemia. But then there are cases when it may be prudent to go to the OR. And some of those cases are if the patient demonstrates signs of peritonitis, that would suggest that there is some sort of perforation. Or if on imaging, maybe the ER got a CT scan or an upright chest x-ray that suggested some level of free air, then that would necessitate a trip to the OR. And then you'll see in a subsequent picture, but sometimes patients will perforate into the retroperitoneum. So the rectum, most of it is extraperitoneal. And so if patients perforate there, they don't necessarily spill poop into their abdomen and get super sick, but they may spill poop into the area behind their abdomen, which is called the retroperitoneum. And that can also make them super sick, but they wouldn't necessarily demonstrate signs of peritonitis. But if that is seen on imaging, that would necessitate the trip to the OR. Then there are patients who maybe they're not able to tolerate removal at bedside. So that would generally be an indication for the OR. And then when you're in the OR, you got to prepare the patient that they're probably going to get opened up. You're probably going to have to potentially remove a portion of their colon. And if they've perforated, they may require a colostomy as well. Anybody know what this thing is? Yep.
Pasty brush.
It's a bell. Yeah, when I first saw it, I thought it was like a brush
Yeah.
with the bottom part being kind of the base or the stand of it. But no, it's a metal bell. And obviously only the handle got in, but according to this journal write-up, it got stuck and perforated. It kind of, because of the anatomy of the rectum and this kind of the shape of the sacrum here, what happened is it kind of dug through the posterior aspect of the rectum and caused a retroperitoneal perforation. So that patient ultimately got an XLAP resection, fecal diversion, so they got a colostomy, and then they got some white drainage as well.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.